Okay, thank you very much, especially to the Libyan Obs and Gynae and Fertility Society to invite us, the group Quirón Salud from Spain and myself as Fertility Director of the Fertility Campus in Quirón Salud Barcelona, Hospital Quirón Salud and Centro Médico Tecnon, to give you a lecture on a global vision of the IVF market trends in IVF in the 21st century. If the objectives of this talk will be to give you a global snapshot on infertility and the continuous in ART cycles, especially in Europe, the demographic changes in the patient's population, especially after the COVID, that's important for us, the new trends to improve and to increase the take-home baby rate, the development areas in the IVF laboratory to improve the clinical pregnancy rates and the clinical live birth rates, and the future in ART. This slide is a summary of what we see, all of us, in our IVF clinics every day. Young women coming to you thinking, well, I am ready to have a baby. Do I prefer to start with my career? Shall I freeze my eggs or shall I have IVF as a prevention in the future? So a young population now is facing the possibility of freezing the fertility for the future because they have the technology to do so. But it's clear for all of us doing obs, gynae, and fertility, and I'm sure in Libya you have the same problem, the reduction of fertility rates and the changes of the age when women are having babies. The best reproductive years, you know very well, are, as you see in this slide, from 20 to 30 years, when the 30% chance to get pregnant monthly, it goes down to 20 and even 5% after the age of 40. So time for the ovarian age makes difficulty having baby at elderly ladies. But that's happening all over the world. Globally, women are delaying the time to have the first baby. And again, the fact that mothers wait so long to have the first baby, IVF, of course, it's increasing in all the countries all over the world. If you look at the demographic changes that we have in patient population, especially after COVID, it was a worldwide pandemic, and it was an effect dropping down the access to fertility. And then, of course, after 2-3 months of closure worldwide, the IVF units start to work again, and there was a recovery that started at the end of 2020. Why do we can say that it's been a global increase in number of cycles during 2021? After COVID, patients thought, well, I better have the baby now because I don't know if another pandemic may come or I may have more problems later on if another COVID comes up. There was an overall worldwide growth in 11% compared to 2020. I'm talking about 2021 figures on IVF cycles. Elective oocyte freezing. Remember the first slide when this young woman is asking you or thinking, well, I have a baby, I must freeze my eggs. That's grown 25% and 40% in some clinics from America and Europe. So women freezing eggs at a younger age in case they want to have babies in the future. And the cycle number now have started to decelerate in 2022. What happened in our country? In Spain, this is data from the Spanish Fertility Society, where we did need 150,000 cycles of ART in the year 2019. Look at that, 70% of the patients that have IVF in our country in 2019 were over 35 years of age. And why is this important? Well, because if women are having babies at an age over 35 or 38, then we need to change the way we work in ART. If you look at the final goal, this slide for me is the best of the talk. If you look at the final goal in ART, is to shorten the time to have a baby through IVF. People today want to have everything immediately, so we have clinical strategies with the antagonist protocol, using the right medication, and preventing cycle cancellation. With laboratory technology, we now can assess the best embryo for transfer with highest implantation rate with time-lapse technology. Embryo freezing or vitrification with the semi-automatic systems can have more embryos available for transfer. And again, if you look at the patient outcomes, the probability of having a singleton baby at home the quickest possible. But then we have to be able to give to the patients a measure of efficiency on IVF. That's the cumulative live birth rate per started cycle. So as ICERI committee agreed in 2020, the efficacy in terms of cumulative live birth rate per started cycle is safety, avoiding ovarian hyperstimulation, and reducing the multiple pregnancy chances. Having a good number of oocytes depending on the age of the patient and the ovarian reserve. The antagonist cycle, IVF antagonist with agonist trigger to avoid if there's a risk of hyperstimulation, and single embryo transfer. We have to be able now to select the best embryo with the highest chance to implant with a new technology in our IVF laboratory. But who can tell you which one is the best number of oocytes to achieve more pregnancies? We all know now that the more eggs you have, the more embryos you'll get, and the more chances to have a pregnancy on any IVF cycles. So more oocytes produced give you more chance of pregnancy. That is very well accepted. And there is evidence worldwide with all these many publications all over the world that if you increase the oocyte number up to 20, the cumulative live birth rate can even double in any women. So the number of eggs you have, again, is efficacy of the treatment after all. But remember about 10, 15 years ago, we were concerned that if we had more embryos, we may have more genetic abnormalities. That's completely now destroyed. Now we are so happy that the more oocytes we have, the genetic quality of the embryos is not going to get affected. So the age of the woman, not the number of oocytes that we have, affects the euploid rate. So the more embryos we have again, the more euploid embryos we may have in any woman. If you look at the oocyte number and time to pregnancy, it is quite clear. If you look at the hold on a second, at the slide on shorter time to pregnancy following euploid transfer, we know that if we transfer an euploid, genetically normal embryo, we will have more success on the pregnancy. But we have a problem. Imagine you have a patient of 35. You know that to get an euploid blastocyst, it's about 60% rate. Well, you will need 5 oocytes. On a 35-year-old woman, that's quite okay. What happens if you have a 40-year-old woman when you know that the euploid rate is only 30%? You'll need 9 oocytes. That may be very much complicated. But what happened when we had a 43-year-old woman when the euploid rate is 20%? You may need 16 eggs to get an euploid embryo. So as women grow or get older and they have less ovarian reserve, the chances of having an euploid embryo will decrease dramatically. So if we go again to the same, if you want to maximize the clinical live birth rate, we need, again, to stimulate with the best medication and the best protocols. We all, especially in Europe, move from urinary medication to recombinant medication. We know that LH may be necessary, especially in aging population of patients. We move to agonist to antagonist, and agonist trigger when there is a risk of ovarian stimulation, severe ovarian stimulation. So we gain on safety, efficacy, and efficiency on the IVF scenario. This paper is so interesting that was published in The Guardian a couple of years ago. If I tell you that the UK IVF success rate has tripled in the last 20 years, I mean, it's fascinating that we managed to increase by overall 18% of live birth rate per cycle of IVF. Why? Because we are better on treating women knowing her antifollicular count and anti-Mullerian hormone. We individualize the control of ovarian stimulation. We use antagonist cycles. We combine recombinant FSH and LH. The IVF lab technology that we have is superb. Vitrification has changed. Freeze-all technology with the frozen embryo cycle with the progesterone values to guarantee the frozen cycle works even better than 5 years ago. Embryo selection through PGTA, and of course, single embryo transfer. How can we I said that simplification with efficacy and safety is very important. How can we make a cycle easy for a patient? Well, if we get a good oocyte number just at the first stimulation, as my friend from Boston IVF, Michael Alpert, said, one and done. On one stimulation, if you can get 10, 15, 20 eggs, that's it. Cycles shorten, less duration, will have to be easy and flexible, little risk or zero risk, little cancellation, little multiple pregnancy rates, and no extra embryos left. I always said that British or American, the language, the English language is very easy to understand. If I tell you that we did the 3 A's in IVF, age, intrafollicular count, and anti-Mullerian hormone, you have enough to individualize on the treatment, you will agree with me. That you have to make sure with these 3 A's in IVF, we have to be able to give an optimal response, avoiding the iatrogenic poor response or the iatrogenic hyperresponder. So with these 3 A's, we may be able to give the best treatment for the patient. But then it's easy, fine. We must optimize the number of oocytes to maximize the cumulative live birth rate. How do we do that? Okay, we have very good now gonadotropin that can optimize the oocyte number in normal and high responder. LH should be given to every woman. I think we should be able to individualize with the new modern prints that we have today, that we give exactly the dose that you want, the amount of FSH, and the amount of LH. So medication will help you as well to give you much better results. We move in Europe, especially from urinary to recombinant gonadotropin. Why? Because the consistency, the batch-to-batch consistency in some recombinant, especially in folitropin alpha recombinant FSH, it's 98.4%. And this is very important because you know the amount of medication that you give to the patient. It's good for the low responder and it's good for the hyper-responder. We know that recombinant FSH with the field by mass technology, a part of the consistency batch-to-batch, produce more oocytes and more embryos with a lower total gonadotropin used in normal responder. We know that with recombinant, we'll get more oocytes, and of course, we'll get more embryo. And remember from the very beginning of the talk, the more eggs we have, the more embryos we have, the more chances of having a live birth rate. But what's happened with the low ovarian response? We know that this is an epidemic. I'm sure in Libya, in your country, you have this problem. 80% of our patients are 38 or over. So we have probably over 40% of our patients will be low responders. We know that the LH given, especially recombinant LH, has a significant effect in these severe or moderate poor ovarian responders. We're talking about efficacy, about GnRH agonists, GnRH antagonists. If we agree 98% of our patients go on a GnRH antagonist cycle. I don't know in your country, but I'm sure you're doing the same. Agonist is completely forbidden in Europe now. So why? Because the treatment with the antagonist will be shorter, the time between cycles is shorter, and ovarian stimulation is practically disappeared. And that shortens time to birth. Little cancellation, better tolerability, and dropout rates. And why is important the antagonist cycle today, especially cancer patients? You need time to get as much number of eggs as possible. So we can do the do-a-steam protocol. We start the stimulation for 12 days. We do the agonist trigger because it's an antagonist cycle. And 5 days later, we start the second stimulation. So in 1 month, we have 2 stimulations. So that's very efficient for breast cancer patients or patients that are accumulating embryos for pre-implantation genetic test. But the fact that's for me more relevant in the new technologies is the freeze-all technology. When you have a high responder. I mean, when I was training in New York or in the UK 25 years ago, we had patients going to ITU, intensive care unit, for a hyperresponse and hyperstimulation syndrome. And I've seen patients dying on that. Today, thanks God, we don't see that anymore with the antagonist cycle and the agonist trigger and freeze-all technology when it's necessary. So combining the best protocols and the drugs to maximize safety and efficacy, we basically have the option of freeze the embryos and avoid the hyperstimulation risk. What happened with the IVF laboratory? I have a very good friend that told me one day, you can be a very good doctor and do a very good IVF cycle and have 10 eggs and a good sperm. But if your IVF lab is not good, that may destroy your cycle. But it's also the other way around. I may be, a middle sort of results doctor, not stimulating very well, not to have all the new drugs, technology recombinant, etc. And, fair work on the medical aspect, but my IVF lab, if it's very good, may save this. So how important is to have a good IVF laboratory? Changes that you see, vitrification. I'm sure you agree that this is the best changes you have now in the IVF lab in the last 10 years. Vitrification for avoiding ovarian hyperstimulation, vitrification for social reasons, women that want to delay childbirth or want to freeze their eggs for another time in their life, or freezing embryos for pre-implantation genetic test. In our unit in Barcelona, in Tecnon and Quirón, in 2 IVF different labs, the fresh embryo transfer has decreased almost 50% in 4 years. So we're freezing much, much more our vitrification with embryos and eggs, much and much more. Pre-implantation genetics test on day 5. We don't do day 3 embryo biopsy anymore. We're doing more and more PGTA for an euploidy or for rare diseases, because our population, as I said, is over 38. And we know that at that age, the chances of having abnormal embryo is going up. And why is important PGTA on day 5? 3 very important things. We transfer little embryos. From 1.5, we transfer 1.1. Pregnancy rates are going from 48% to 60% in the PGTA day 5 freezing embryo technique today. And the multiple pregnancy rate has dropped from nearly 20% to 4%. So this is a really cost-effective treatment for our patients going through IVF. As I said, the freeze-all strategy in the last 4 years has increased to 16%, as I said, for freeze-all for risk, vitrification for postponing maternity, or for patients going to pre-implantation genetic test. And if you ask me to finish how I can define the future in ART, in assisted reproductive technology, I think the most important here will be artificial intelligence for stimulation, lab, and receptivity, not that far. How automatic will be all the technology that we have in the IVF laboratory. How the patients can do a self-hormonal test with saliva and with a drop of blood in the fingers, with a home assay, and send you the results. And again, the IVF scan controls. The embrace, I think, is the future. Remember, if you know, and I'm sure you do, that 80% of IVF cycle failure is due to embryo, well, what happened with endometrium, thrombophilias? What can we improve on that will help you on the future of the patients. And the Embrace technology, remember, will be able to do an embryo genetic analysis, not with a laser biopsy of the embryo, you may damage the embryo, just taking culture media and analyzing the result. So for me, the take-home message, if I have to give you a summary, and of course we can have questions later on clinical decisions to maximize the outcome of your patients going through IVF. We all know that more oocytes, it's what we have to get. Try to get, depending on the age, the optimal number between 15 and 20, as Session Kara mentioned to all of us. Not all patients are the same, so remember you have to individualize control of ovarian stimulation, looking at the 3 A's, age, AMH, and anthrofollicular count. The identification of the FSH or LH starting dose is very important. Remember, once you start with the medication, you start selecting the number of eggs, so you have to be sure that you select the best number. Vitrification, yes. It looks that in patients with risk of hyperstimulation, if you have progesterone issues, of you going through pre-implantation genetic test, the best thing will be to freeze your embryos before embryo transfer. Remember the aneuploidy, now we know that's independent of the oocyte number. So if you have more euploid embryos, more chances of having a pregnancy. And remember that today with the PGTI technology changes between IVF centers, so you have to have a very good IVF lab and super embryologists to make sure they do the best techniques on the PGTA. And then try to improve implantation rates. Personalized embryo transfer in the future, make sure that you do single embryo transfer, chromosomal or genetic normal embryos, and again, with all the technology that can help you in the failure of transfer. And always remember, we have to evolve with the patients. We have to adjust, we have to adapt, and we have to understand. Every patient is different, and we have to understand that. Thank you very much to all of you for listening.